All right. Good evening, everyone. I want to welcome you all and thanks for joining the Alliance of Sleep Apnea Partners live event tonight. I just want to introduce to you that I actually want to mention that we just concluded Sleep Apnea Education Week this Sunday, and this was our third year that we celebrated Sleep Apnea Education Week. And the goal of the Education Week is to promote, education and awareness around sleep apnea, especially around diagnosis and treatment, because I think there's a need to educate the public on this topic. One key theme for this year's Sleep Apnea Education Week was around the theme of partnerships. And so tonight I'm delighted to present this event to you in partnership with the American Academy of Sleep Medicine. So before we get started, I just wanted to do a brief housekeeping. I want to encourage all our viewers to ask questions in the Q&A box, not the chat, but Q&A, and please continue to ask us questions throughout the session. I also want to remind you that the importance of evidence-based information. So if you have questions and are looking for resources, please come to us at Alliance of Sleep Apnea Partners or the American Academy of Sleep Medicine. I do also want to mention that I had the pleasure of speaking with Dr. Audrey Wells on the topic of sleep apnea innovation, or what's working, what doesn't, what's coming. So that webinar is available on our YouTube. And so today's conversation is somewhat is a follow-up to that conversation I had with Dr. Wells. So let's get started. I want to introduce you to our panelists today. So first, I'm going to introduce you to Dr. Anita Shelgikar. She is the professor of neurology at the University of Michigan Medical School. She's a sleep physician, and Dr. Shelgikar currently serves as the American Academy of Sleep Medicine as its president, and is also the past president of the AASM Foundation. Welcome, Dr. Shelgikar. And then we have nice to have you here. And we have Dr. Mohammed Osama. He is the dual board certified sleep medicine physician and one of the leading voices in sleep medicine today. He practices at Multicare Health System in Greater Seattle. His clinical and research work focuses on the intersection of obstructive sleep apnea, obesity, and cardiometabolic health, with a particular interest in how GLP-1 therapies, such as tirzepatide, can reshape outcomes for patients with sleep disordered breathing. He's also certified in obesity medicine. He also serves, and in fact, he also serves on ASAP's medical advisory board. And then we have Lori Schulman. Lori has more than 25 years in building early stage sleep tech, health tech, and digital health companies. She's been very successful, and she says it's been a rewarding career for her. And one of her aha moments occurred in 2011 when she joined her first sleep medical device company, offering a new therapy that would give patients and clinicians an alternative treatment option for obstructive sleep apnea. Lori is also on ASAP's board of directors. So welcome, everybody. So just to kind of start off our conversation today, we're at a pivotal moment, I feel, in when it comes to sleep apnea, and because there's so much innovation happening in this space, just not treatments, diagnostics, just treatments, just a lot that is going on, and I feel like a lot of patients don't know that there are new options coming in for treatments. Many continue to be underdiagnosed and undertreated. There is this link for sleep apnea to chronic conditions. ASAP has done some work on looking at the link between obstructive sleep apnea and obesity. And again, the belief that there are limited treatment options with existing challenges for management. And I think some questions might come up around that. So, there's a lot to cover when it comes to innovation. I thought let's just focus on treatment for today, but we will open up if there are questions on diagnostics or, wearables or something. We'll see, we'll try to answer those as well. But let's start off with what works. CPAP has been the gold standard for so many years. It's evidence based. We have good, data on that how it works. There's evidence to support heart health and challenges, but people continue to sort of struggle with CPAP. Um, and so let's just kind of talk about that a bit. Where are we with what we know about CPAP? And there is an issue with adherence. If you want to just sort of address that, and I'll pose that to Dr. Shelgikar and also Dr. Usama.
Sure. Obstructive sleep apnea is something that is, as much as that we have cohesive diagnostic criteria, we do find that there is still an individual component to it, in terms of how people adapt to treatment, what kind of therapies may be best suited for each individual. And treatment adherence is something that we work on with our patients when it comes to CPAP therapy. Some people take to it right away. Some people may take many months to get used to CPAP therapy. It is a different skill set. It's new equipment. It's something new to incorporate in your day-to-day routine. So it can be, hard, and that's okay, to acknowledge that and for us to collectively acknowledge that. But, when you partner with your healthcare providers, with your sleep medicine clinic, that's what we are here for, is to help with troubleshooting, finding the right mask, making sure the pressures are both effective and comfortable. How do we work towards getting to use it all night, every night, for it to be most effective? So there definitely can be tried and true strategies to use to win that troubleshooting process to help with adherence and ultimately to help get a better night's sleep.
Great, thank you. Dr. Osama, do you have anything to add?
I think that in general, CPAP adherence gets a lot of bad press. I think part of that is also because we as a field, we track it very rigorously. Like if you talk about other chronic medical problems, there is, I haven't seen like, that kind of tracking anywhere. People have tried a bunch of models like, pill opening sensors for, these chronic medical problems. And if you look at, even long-term medication adherence for diabetes or hypertension, like, it is like, 50 to 60%. It's just human behavior. It's not something that is exclusive to CPAP. But having said that, a lot of people, what happens is that when they're not able to tolerate it, they are hesitant to come back to the sleep clinic. That I have some patient who came back after like 4 or 5 years and said I could not tolerate it, and hey doc, I just did not want to waste your time. And but there are strategies we can work with, and if someone is not tolerating, then there are alternative options out there which we can help them with. So I tell my patients that we are starting this therapy, but if it does not work out or if you're having any issues, please reach out, because a lot of those issues, they're facing, they could be due to pressure intolerance, they could be due to leak or dry mouth. All of these things, they are addressable and manageable.
In your experience, and again, this is something I wonder how many patients actually know that, and is that an educational opportunity to let them know? Because people just think that they can put on a CPAP mask and it's just going to work, but there is some troubleshooting that needs to happen, right? And what kind of support that sleep clinics can give them in navigating that process?
Yeah, it depends on, what exact issue they are having, for example, a lot of time the issue is mask comfort or mask fit, and there are so many different kind of masks. I tell them like, there are 50 different kind of masks, more than that actually. And so we can find a mask which suits your facial size and structure and which you like. And I tell them that they can reach out to their medical equipment company, and like, we can work on a mask refit. If they're having pressure intolerance, then to start like, make them acclimatize, we can start with lower pressure and slowly like, go up on it. If they're having dry mouth, a lot of time that is due to leak, so we can address that and fix that. And so there are so many strategies we can work with them to address whatever problem they're having.
Fantastic. So tell us, what are the innovative therapies now? So after CPAP, what do we have now? suppose somebody is unable to adhere to CPAP or is having issues, what are the sort of the next level, therapies?
So there's oral appliance therapy, there is positional therapy, which is avoiding back sleeping and sleeping on one side or sleeping with the torso elevated to help improve sleep apnea from that positioning type of standpoint. Improving nasal breathing also helps with, it's not usually a standalone treatment, but can help with getting more comfortable with the mask, for example, or more comfortable with an oral appliance. There is one medication so far FDA approved for the indication of moderate to severe obstructive sleep apnea in the setting of obesity. There are more medications coming down the pipeline. I think the field is going to be evolving dynamically in short order as more of these medications become clinically available to patients. There are upper airway surgeries, ones that have been around for decades, things such as hypoglossal nerve stimulation. So there are many, many treatments. And the exciting thing as the list grows is that we can find combinations that work best for each person. We don't have to go in a one size fits all type of approach to treating sleep apnea. So that's often what we do is really finding the strategies that works best for each person.
That's
Yeah,
fantastic.
yeah.
Yeah.
I'd like
That's
to
good.
add to
Go
that
ahead.
also.
Sure. Yeah.
There's a lot, I mean, there are other ways we can treat patients. There's negative pressure as well, negative pressure instead of positive pressure. And then, of course, there's the KPAP device. I'm not pushing any product, but I'm just saying there's other ways that we can help make either the CPAP more comfortable besides the mask with the flow. And, as you mentioned, positional aids, there are many new positional aids coming to market. And there are some preemptive surgeries that I'm looking at, or pharma solutions that are coming as well. So it's pretty exciting to see what's coming down the pipe.
No, absolutely. Let's talk a bit about the GLP-1s. I mean, again, there is some, not everybody is a candidate for those. Dr. Osama, do you want to talk a bit about those? Because I think that kind of revolutionized some of, the treatment landscape for sleep apnea. And tell us a bit more about that, because we got a lot of questions from patients wanting to know more about it, and especially around access.
Yeah, absolutely. Thank you. In late 2024, FDA approved this medication, tirzepatide or Zepbound, which is GLP plus GIP receptor agonist for treatment of obstructive sleep apnea, because according to Surmount OSA trial, based on that, it does improve your severity of your sleep apnea. And obesity is a big underlying risk factor for sleep apnea. But it's not the only risk factor. And so addressing that, it is helpful. So GLP one receptor agonist or incretin therapy or GLP plus GIP therapy, amongst all those, right now, the only one that is approved is Zepbound. There are a bunch of more, incretins who are in clinical trial for treatment of obstructive sleep apnea, but they're not out yet. But it's a very good and effective and evidence-based therapy for patients.
And we have, Dr. Shelgikar, we have that one pill that we are all waiting on. Do you want to talk a bit about that?
Yes, I mean, it doesn't have FDA approval yet, but yeah, it's interesting and exciting when we have medications and other types of therapies that are looking at novel mechanisms of action in terms of, targeting different therapeutic potentials as a treatment for obstructive sleep apnea. So this drug, I imagine you're referring to 8109, that is, moving through the process. So it's a combination of oxybutynin and atomoxetine, really targeting upper airway tone, muscular tone, as a means of improving obstructive sleep apnea. So, we will see how the availability and the pricing and the real world access to your question about access, how that works for patients once it becomes clinically available. I think we are learning a lot with the availability of Zepbound and kind of what are the clinical workflows that we need to make it more accessible. What's the type of follow-up and things like that? And What's the type of conversation we need to have with insurance companies to make this more readily accessible for appropriate patients? So I think we will learn those things as new medications become available, but it's really exciting that different medications are targeting different underlying factors to really help with treating sleep apnea that's very diverse across people.
Do you see that once pharmacotherapy becomes mainstream, do you see people moving away from CPAP? And what would be your, conversation with a patient would be because people, do struggle with, trying to manage their sleep apnea with CPAP. And how do you see that sort of landscape shifting or the conversation happening with your patients?
I think the shift that I expect to see is that we are able to provide more options and hopefully get to the point one day where we can personalize the medical decision making in terms of how do we upfront identify what one therapy or combination of therapies may be best for a given person based on their coexisting medical conditions, based on their anatomy, based on the severity of their obstructive sleep apnea, their degree of oxygen desaturation. What are the factors that we can look at in a given individual to say, this is the right treatment approach for you? It's always going to require long-term monitoring, right? It may include trying one's treatment strategy, adding a different treatment strategy, moving to a third treatment strategy. That's why we have long-term follow-up with our patients because it's an ongoing conversation and checkpoint that we need to have with our patients. But I don't foresee that CPAP will exit the scene. I think we will just have more options and be able to better personalize the care for obstructive sleep apnea in the future.
No, that's
I,
good to know. Yeah, go
I
ahead.
just like, yeah, I just like to add that it was my fear when, particularly Zepbound came out for sleep apnea that all of my patients, they will just ditch their CPAP machines, which was my big concern because, as I said, that obesity is one of the underlying risk factor, but, there are different endotypes or underlying pathophysiologic mechanism which contribute to obstructive sleep apnea. But weight loss, it's a chronic phenomenon. It doesn't happen overnight. So those patients, they still need that support of splinting their airway open, which CPAP does an amazing job at while they're achieving that. And but to my surprise, actually, my patients are using their machines more while being on tirzepatide because it's helping them lower their average pressures and it's making the therapy more tolerable for them. So they're using it more. And the future of sleep apnea care, I see a lot like heart failure care because in heart failure, we don't have one medication. We have ACE inhibitor, we have ARBs, we have aldosterone receptor antagonists. We have all these different pharmacotherapies which are hitting at a different mechanism. And similarly with obstructive sleep apnea, I think it should not be CPAP versus GLP therapy or CPAP versus hypoglossal nerve stimulation, or so the combination therapy is gonna be the future, and addressing those different underlying pathologic mechanism targeted to patient physiology and anatomy. That's how I look. So maybe the future of sleep apnea care is gonna be oral appliance plus GLP therapy, or it's gonna be AD109 plus oral appliance, or it's gonna be CPAP plus GLP therapy. So it's gonna be combination therapy. So we have to move away from one type of therapy versus another type of therapy.
And we're still, I believe, we still need to know more about that, right? The type of patient, and that's what you're referring to, the endotypes and the phenotypes. So we did get a question from somebody. How effective is Inspire? People see a lot of advertisements and again, just want to know more about, Inspire and who's the candidate for something like that. And that's also a broader question for who's really the candidate for what therapy, and Lori, I'll come back to on that too. Do you want to go first?
Yeah. So Inspire, the type of a hypoglossal nerve stimulation, it is an approved and evidence-based treatment for obstructive sleep apnea. The question of who does it work for, there are clear criteria for being a candidate for hypoglossal nerve stimulation therapy. And so it's a perfect example of multidisciplinary care, partnership in care. So for those of us who are sleep medicine physicians, but not ENT surgeons, right, we're part of the process of the diagnostic process and determining whether someone's a candidate or not for this device. And then we partner with our ear, nose, and throat surgery colleagues for the rest of that evaluation. So part of it has to do with severity of sleep apnea. Part of it has to do with body mass index. Making sure that central sleep apnea is not more than a quarter of the events that are seen on the study. Again, really making sure that the right person is selected. And so there are a number of kind of criteria up front. And then when we proceed with the referral to otolaryngology, ear, nose, and throat surgery, they will do a diagnostic procedure under anesthesia to look at the anatomy, look at the way the airway collapses to make sure that it would properly respond to that implant and to the type of therapy that it provides. So a really thorough, comprehensive diagnostic process. So it's really hard to say off the cuff. Again, if you go to their website, it's very clearly listed what those entry level criteria are, but then, you do need that more thorough evaluation to know for sure whether a given person is a candidate or not.
And then we can certainly say patients should talk to their doctors first, sleep physicians, to see what
Absolutely.
therapy, works for them well. So Lori, do you have any thoughts on
On
this?
that, sure. No, of course. I think that the neurostims are really great. I think getting the right patient to that therapy is the most important thing. And whether they're going through the DICE procedure, some of the newer ones that are coming up do not require the DICE procedure, is my understanding.
Can you mention what the DICE procedure is? I don't think.
Yeah.
Drug-induced sleep endoscopy.
Yeah.
Yeah, it's a sleep endoscopy. So essentially, the patient's given propofol, I believe, and they're really not asleep in the traditional sense, but the clinician can look down the patient's airway to see where the collapse is happening, whether it's concentric closure or lateral wall closure, and they usually make the determination from that. Some patients are excluded, I believe, based on that information. But there are the newer surgeries that are coming up like that do not, I believe, require the DICE procedure. And so I really don't know enough to speak about that, but I know that that's something that they're trying to avoid, and would it not exclude patients based on that type of closure of the airway.
Yeah, no, thank you for that. Actually, Dr. Shelgikar, can you also just tell us a bit more about central sleep apnea? Not a lot of people know about it, and currently there are no treatments for that, right?
There are treatments. So the American Academy of Sleep Medicine recently updated our clinical practice guideline, published in 2025, about the treatments available for obstructive sleep apnea. So when we publish a clinical practice guideline, it goes through a really rigorous evidence review process known as GRADE. And when in going through that process, really looking at what's the available evidence, what is the strength of the evidence in response to specific questions that have been asked up front as part of that guideline development process. And so it's publicly available on the website too, treatment for central sleep apnea in adults. So there's that caveat, it's in adults, not in pediatric patients. But you can see there are a number of different things, CPAP, different other devices that have the capability of delivering a backup breath as well. Again, depending on the type of central sleep apnea, there may be some other treatments to consider as well, such as pharmacologic therapy, but there are treatments for it. But generally speaking, it's when there is a pause in breathing, but no associated respiratory effort, the way we see in obstructive sleep apnea. So it's when we're looking at a sleep study, it's visually very different appearing from obstructive sleep apnea, and can be associated with different medical conditions, different medications. So again, still requires that thorough sleep and medical evaluation to really deep dive and understand the context for each person, but there are treatments available for it.
Great. That's good to hear. Dr. Usama, you want to add anything to that?
Not for cent. I think Dr. Shelgikar pretty much covered it.
Okay. Well, we have two questions here, and I want to encourage our audience to, again, ask more questions. We have one from Bob Stanton. He says patients often don't have the ability to reach out to ASM or ASAP directly for questions. They use social media support groups for information. How can we improve the quality of information in Facebook or other social media support groups, given these groups can have as many as 92,000 members, generating 1.1 million views in the last 28 days? So he's speaking about a specific support group called Global Sleep Apnea Support Community on Facebook. So do you want to answer the question?
Sure. Well, I think kudos to you and those who are supporting these social media networks to be resources in real time for people with shared experiences. I think that's fantastic and obviously serving a need. On an organizational level, we would love to know where we can help serve that need as well. I think it's nice to have, information from experts, information from people walking in your shoes, and I think different forums, again, serve different needs and different purposes. For example, we partner with ASAP, we partner with other patient advocacy organizations. So if that's something that comes from this conversation of being able to better forge those relationships and those collaborations, that would be fantastic. So I'm, again, thrilled to hear about the support that you and others are providing to people with obstructive sleep apnea, and we would love to partner to better reach people in a way that's meaningful and helpful to them.
Thank you. Thank you for that. We have one other question. What do we know about TEXA, TECSA, and what are the guidelines to address it?
So that's treatment emergent central sleep apnea. The clinical practice guideline that I mentioned does reference treatments for TEXA, treatment emergent central sleep apnea as well. So CPAP and various types of devices, PAP therapy devices that have the ability to generate a backup breath. And again, with close kind of clinical follow-up and making sure that someone's responding well to that treatment.
Fantastic. Let's see. We also have a question, and we can take this into our next, conversation about. There's a question here on CPAP. Does using a CPAP cause nasal congestion?
Dr. Usama, would you like to take that?
Yeah, I mean, if someone is having it it can cause it, like, if someone is having a lot of, like, leak, there are a bunch of causes of nasal congestion. So because what happens is that with the excessive unintentional leak, that humidity chamber which the humidifier maintains inside of your oronasal cavity, that is lost. So your nasal mucosa tries to compensate by that by, like, growing extra to, like, so that the glands, they can produce more mucus. So it can cause nasal congestion. And if we address the underlying leak, that can help in a lot of patients, like, saline sprays or nasal steroid sprays, they can help as well.
So they need to then try that, or just talk to their doctors, or get some help in even trying to find the right mask. Would that help?
Yeah, absolutely. So first of all, if you're having any issue, like, to get advice tailored to your condition, you should talk to your medical team. But in general, like addressing the leak, trying these nasal sprays, it does help, but it does not happen in all of the patients.
Oh, okay.
Yeah, it's not like, happens in all of the patient, but if it happens, then this is something we can definitely address.
Okay, there's a similar question, and I believe you just answered it, but there's a question, another question from Lori S. It says, my nose drips and runs all day. I'm tired of lep, no, petroleum. I don't know. I've never heard of this, but I need to know why my nose constantly runs. Is this similar what you were just talking about? It's the mass leak. Does it, any indication to that? But again, this person hasn't said if they use CPAP. So anyway, let's move on because they have not really mentioned what they do. there's another question. Some days I still feel tired when I wake up. How can I change that?
Yeah, I think hopefully you are connected with the person who's prescribing and managing your CPAP therapy. This is exactly the sort of uh, discussion that we have in follow-up when using any type of treatment for obstructive sleep apnea. If someone it came to us with daytime sleepiness as one of the presenting symptoms, has treatment helped with alleviating that daytime sleepiness? And if the answer is no, then there's a lot of troubleshooting. Is it an issue with the therapy? Is it an issue with the duration of use of therapy? Is it related to the overall number of hours of sleep and the schedule of sleep? Is it related to other medical conditions, caregiver responsibilities, medication side effects? So there's a lot of discussion that needs to be had in terms of really kind of getting to the bottom of what is the cause or the potential causes of persistent sleepiness in the setting of obstructive sleep apnea treatment, to make sure that treatment is optimized and to see again what else is needed alongside that obstructive sleep apnea treatment.
Do you see a lot of patients just coming back to you again saying, I just can't tolerate CPAP? Or, do you see more of those types of patients who are struggling initially and then eventually adapt? Or, sort of, I'm just curious what type of questions they, come up when you initially prescribe that, CPAP treatment.
Yeah, I would say yes to all of the above. Is there a box to check? All of the above. I think there's a range of responses to CPAP therapy and initiation of CPAP therapy. Some people, it's like, wow, this is the best thing ever. This is amazing. I love this. I'm never going to be without it again. And then there's, I'm about to throw this out the window, so we need to have a conversation now. Otherwise, I'm never using this again. And everything in between. And I think just as unique as individual people are and their circumstances are, same with their response to CPAP and what the hurdles are with getting used to CPAP therapy. So I would say yes to all of the things that you described. But as we've mentioned before, there are things we can do. We through the clinic, through the medical equipment provider, partnering with primary care. I mean, there really are so many things that we can do to help the treatment be comfortable and usable on a regular basis. So the take-home point there is to keep talking with the person who's prescribing your treatment to make sure that it's optimized.
It's great because I was one of those people. I barely tolerated, tried for a month, gave it up, came back 4 years later. So now I won't go without without my CPAP. So, Dr. Osama, do you have anything to add there?
Yeah, I would just like to add that, if you're not able to tolerate the therapy, please reach out because there are things we can help and either make the therapy troubleshoot and make the therapy more tolerable for you. But if you cannot or if you do not tolerate it, CPAP is not my child. There are so many other treatment options, and it's okay, you don't need to feel guilt about it. It's okay, if you don't tolerate it, if you're pretty sure, that is not an option for you, then come to us because our goal is to do mean disease alleviation. So CPAP is very effective, but if you cannot tolerate it or if you do not put it every night, you don't use it every night, then that effectiveness goes down the drain. So we need to have some sort of therapy that is giving you that clinical benefit and doing that mean disease alleviation.
And
Yeah.
yeah, go ahead.
Can I just add on to that as I fully agree? And I would say that the troubleshooting and the clinical follow-up is required regardless of what type of treatment is pursued or combination of treatments is pursued for obstructive sleep apnea. We do consider this a lifelong condition for the vast majority of people. And so it requires ongoing follow-up. And so I wholeheartedly agree. It's not a one and done, like you tried to CPAP, you tried to mask. I'm sorry. There's so many more things that we can offer, but it does require that ongoing connection, that ongoing conversation to make sure that treatment is optimized and when do we need to pivot and think about other things.
I agree. I would also add that, I think it's important that patients know that they shouldn't just not come back and see you. So it's important that you've given them these options, that they know that you're a resource to go back to see the clinician that you started with or at least get a recommendation to see somebody else. But, so many times I've heard patients fall off the wagon, so to speak, and they don't go back and they're still suffering. And then the comorbid conditions continue to present, and they could have been on some treatment. But it's important to get back to talk to the doctor if you're having a struggle and to find out what else is out there.
No, that's a good point. Okay, we do have a question here. It's a question for the panelists. I am representing American Academy of Dental Sleep Medicine. This is Dr. Preeti Chitkopekar, and she said, I have a concern and a question. What percentage of your OSA patients are being treated with CPAP or being tested with a repeat sleep study, like a 90-day titration sleep study, or even at the end of 12 months, if not more often? And why is it that taking patients through repeat sleep study, like a hybrid study, is not the norm or a standard protocol adopted by AASM?
Yeah, sure. I'm happy to take that. So we really, try to practice in accordance with our clinical practice guidelines and with other published evidence-based guidelines. And so our guidelines currently do not call for a certain time frame being the indicator for a repeat study. It's really based on the clinical features of a patient. Is there persistent sleepiness? Is there evidence of untreated or suboptimally treated obstructive sleep apnea that would merit further diagnostic evaluation? So again, it's part of that longitudinal follow-up with the patients in terms of deciding if and when a follow-up study, whether it be a diagnostic study or a study with use of a treatment option or a titration study, retitration study, even deciding what type of study requires that clinical evaluation. So, but it is not based solely on time.
Mm-hmm. Okay. We have another question here. What about treatments for mild apnea and upper airway resistance syndrome, which are sometimes harder to treat?
So mild sleep apnea, it should be treated if someone is symptomatic or someone has hypertension or a comorbidity. So it should be treated, and there are different treatment options. There is oral appliance, there is CPAP therapy. There can be like positional therapy depending on your individual sleep study and all of that. So for mild sleep apnea, there are treatment options. For upper airway resistance syndrome, it's more of fighting with the insurance, trying to get a treatment option approved. That is a real challenge. If someone is symptomatic and having, symptomatology with it. I would like Dr. Shelgikar to add into it if there is something missing.
Yeah, absolutely. So we do consider upper airways resistant syndrome to be kind of under the umbrella of obstructive sleep apnea, and one of the sleep-related breathing disorders. I wholeheartedly agree that this term mild is one that there's so much nuance around the word
Right.
mild, right? And mild in different scenarios, in different clinical settings, totally unrelated to sleep, may imply something that does not need to be readily addressed and can be watched. And that may be true for some people with mild obstructive sleep apnea, but if they have, high blood pressure, if they have daytime sleepiness, depending on what else is happening with them, that word mild may be misleading in terms of, does this need to be addressed right now? And oftentimes the answer is yes, this really does need to be addressed because of these other factors related to high blood pressure, sleepiness, and so on. And so, again, what type of treatment is best for people with mild sleep apnea? Again, we take these other things into account. Right? What are the other medical conditions? What are the other factors that we are considering? What is the anatomy of the upper airway? And so again, kind of case by case decision making, but it should be treated if there are symptoms.
And that's such a good point too, because a lot of patients do get, diagnosed with mild. And then again, of course, I always say mild doesn't mean anything if you're still showing symptoms. Lori, what do you hear when you work with innovators? I mean, does this conversation come up
Yeah,
around
it does. It comes up a
you?
lot. I mean, the positional sleep apnea part. So some patients have a very high percentage of positional sleep apnea. And if they do, the question is taking that into account for the therapy. Some of the positional aids are better than others. There are some new ones coming to market, which I'm really excited about. Dr. Usama saw one last year at the sleep meeting that I showed him, and that's moving along. And yeah, I'm really excited to see what else is coming up to help with that. Things that are less invasive. I mean, the oral appliances are great. I think some of them are better than others, but I do think that we can do better with some of these therapies that are invasive and try to make them less invasive if necessary. I use that as like when people ask my opinion on these things, I like to say that it's really about trying to do the simplest thing that will be the most effective, right? And of course, I'm not a clinician, so I always defer to the doctor, but I do think that it's important that they take all the different options out there. And many times, all the options are not mentioned when they meet with the clinician. So I think it's important that those conversations happen with the clinician.
No, thank you for that. We have a question here. As Dr. Osama mentions, in the US, how much of treatment protocols are dictated by insurance authorizations rather than clinical practice guidelines?
That's
Take
that's a
that.
$1 million question. I mean, I don't know how to answer that. It's there are certain treatment options which are FDA approved and guideline approved, but insurance they follow their own set of guideline. Majority of time they are evidence based, but sometimes they don't approve therapy which is evidence based and want us to go through different steps. um, but I don't know what percentage it is to answer that question.
Dr. Shelgikar, do you have anything?
Yeah, I would agree. I think it would be really hard to give an accurate percentage estimation in response to that question. And as we all know, even amongst payers, there are differences in coverage, right, for the same diagnosis, for the same intervention, depending on various factors that the payer has established as part of their decision making. So it is without question an established part of our practices to have to do prior authorizations and things like that and communicate frequently. We have teams and staff who communicate all day long with payers to help our patients get evidence-based diagnostics and treatments covered. But it is definitely a challenge, I think, that we all experience from different vantage points.
How do we approach treating? OSA is connected to so many chronic conditions, right? So when it comes to treatment, how do you approach that? I mean, do you talk to your patients about if they have other chronic conditions, or it might come up that they had underlying OSA, and then how is your approach, and how do you see that in the future? With all these new innovations and treatments coming up. I mean, we got a glimpse with tirzepatide, right? So with obesity and OSA. And so what's your thought on that?
I find it very helpful. I think it motivates a lot of patients if they have underlying atrial fibrillation, particularly if their cardiologist tell them that, hey, we gotta need to treat your sleep apnea, because I'm just a sleep guy, I'm telling them, put on this and go to sleep. But if the cardiologist tell them, they're like, oh, this guy's in charge of my ticker, so I gotta listen to him. So but jokes apart, I think addressing, telling them if they have a comorbidity like atrial fibrillation or ischemic stroke. So tell them, treating your sleep CPAP will help better control of your atrial fibrillation, will help better control of your high blood pressure, which we have evidence, it prevents recurrence of ischemic stroke. So talking to them about that, I think it's so important because it gives them the motivation and to use it every night. And also, they then understand the disease burden. I think, the if you just tell the patient that here is your CPAP and go use it, and they
Mhm.
don't understand the rationale behind it, then it can be difficult to for them to use it and to understand why it's important to use it. So it's form of informed decision making that we talk to them about the comorbidities and how using this treatment option would help those coexisting conditions.
No, that's a good point. And Dr. Shelgikar, I mean, we know there's a link to dementia or cognitive decline, Alzheimer's disease, and you're a neurologist, right? So, how do you have that conversation? Do you again find that sometimes your patients had underlying OSA, or again, how do you, manage those conditions together?
So I think this is another realm where the partnership across specialties is really highlighted in the care and management and long-term follow-up of sleep disorders and of our patients who have various sleep disorders. So the American Academy of Neurology has identified sleep as one of the key factors for brain health across the lifespan. The American Heart Association has identified sleep as one of life's essential eight. So there are so many other medical specialties that are recognizing the link between disordered sleep and clinical sleep disorders with these other coexisting conditions, such as various cardiovascular diseases, including brain health diseases such as dementia and other neurologic conditions. So we are seeing referrals from our peers in these clinics, in neurology clinics, in cardiac clinics, in primary care clinics, and vice versa, when we are seeing patients and we are taking our history, or when we're looking at a sleep study, we may find abnormal heart rhythm that has not yet been diagnosed, and then that prompts a conversation with a cardiologist or a referral to a cardiologist. Or in our discussion of how disruptive is daytime sleepiness to you, or how disruptive is your sleep schedule to you, we may then have a conversation about change in cognitive function, change in memory, and that too may prompt then a referral to a neurologist for a deeper evaluation. So this is a constant, many-way conversation with us and patients and other specialists, primary care providers, to really kind of globally take care of not only sleep disorders, but all of the associated conditions, because all of us have the ultimate goal of helping people improve their quality of life, right? We do it through hopefully helping people have better sleep. But it's a way to partner with people who are achieving that through different means.
Oh, that's good. And then again, this is something I think we'll hear more and more. And then I think it does tie into this whole innovation aspect too, as more treatments come up. We do have a question here from Natalie Bell. Talk a little bit about the comorbid conditions that women experience. I've recently been diagnosed with severe OSA, and I'm a woman. I find information online on sleep clinic websites about women's systems such as chronic fatigue and unrefreshing sleep, insomnia and difficulty staying asleep, mood changes, depression, anxiety, morning headaches, brain fog, and poor memory. But I don't find people talking about it even on social media. Why?
This is such a timely topic. As Dr. Mallampalli knows, at the AASM, we have a Women's Sleep Health Task Force. Dr. Mallampalli is part of that task force. We just held a summit with a number of different stakeholders, including patient representatives, because this is such an important topic. And we are seeing, as our field continues to grow and evolve, that even our diagnostic criteria may need to be nuanced, the way we've been talking about how our treatment options are nuanced, right? And, maybe there do need to be uh, different or more nuanced criteria depending on the stage of life and sex of men compared to women and so on. And so there is still so much that we need to learn in this space. And I am grateful to you for bringing up these questions, because so many of our patients come to us with these questions, right? Or things are or all attributed to many menopause and nothing else. And sure, there may be factors there, but these things again are more complicated than just being attributed perhaps to one root cause. And so this is definitely a hot topic in the field of sleep medicine, in the field of sleep research. And so, keep asking the questions when you go see your healthcare providers, because it's only when we learn from our patients that we understand what questions need to be further investigated, that need to be studied. Where are the areas where we need better diagnostics and more robust treatments so that we can serve our patients? So more to follow, hopefully in the near future. But this is definitely something that's getting a lot of attention now.
And we now know more that women present with sleep apnea differently than men do, which we didn't have that kind of in-depth, information before. So I think the field is evolving too, and there's more attention being brought to that. There's another question here. Does the menopausal or postmenopausal state affect onset or prevalence of sleep apnea?
Yeah, so it does. There is after menopause, there is increased risk that women face of having obstructive sleep apnea. So the answer is yes.
Okay. And Dr. Shelgikar, do we know how hormone therapy works? I mean, does it improve sleep apnea in women? Do we have any information on that?
Yeah, so we aren't using hormone replacement therapy as an obstructive sleep apnea treatment. Uh, that being said, going back to the prior question about perimenopause and menopause and its influence on obstructive sleep apnea, as Dr. Usama noted, it does influence the likelihood of having obstructive sleep apnea. We do know it can be disruptive to sleep for through a number of mechanisms. And sometimes those end symptoms overlap. Nighttime sweats, is that due to menopause? Is it due to obstructive sleep apnea? Is it due to both? And so there may be a role again for faceted approach to treatment, thinking about hormones, thinking about obstructive sleep apnea, thinking about how these things can be used in combination depending on what types of symptoms people are having. So it is definitely a conversation to have with primary care or OBGYN, and like these things should be done in parallel. If we are managing a diagnosed sleep disorder, to continue that conversation about managing other menopausal symptoms, because we do know that it can directly affect sleep.
Right. Lori, I want to come to you because you've been in this field for
I
so
have,
long,
yeah.
and you've heard a lot of conversations around women and sleep apnea. Do you want to add something
I
to
would. I'd love to say, just add to this conversation that, women, as we get older, we have, we have estrogen, and when we lose our estrogen as we reach menopause, perimenopause, and menopause, our risk factors are equal to men. So with the prevalence of OSA is higher as we get older. And a lot of that has to do with, I believe, the tone of the airway. All of these, we have estrogen receptors in every part of our body. And so, in all of our organs. So when we see we're better than, we're not as impacted by a lot of the conditions that men have until we get to perimenopause and menopause, where we see more of these chronic conditions affect us. And that a lot of that has to do with the estrogen and progesterone.
Mhm. Let's bring up the topic of COMISA, comorbid insomnia and OSA. And I think a lot of women, I mean, again, it's very common in women, right? And how do you go about, again, treatment for that? And what's that approach when you do see, patients exhibiting both insomnia and OSA? Dr. Shegikar, you want to go
Sure.
first, and then
Sure.
Dr. Osama wants to, yeah.
Yes, we do know that these things coexist, right? And again, is insomnia a function of sleep apnea? Is it a separate clinical sleep disorder? Oftentimes, the two disorders can coexist in the
Right.
same person, and so some common themes coming up in terms of the need for long-term follow-up when and for each person, do we in the course of our evaluation, are we addressing both of these things at the same time? Are we going to go in a stepwise fashion and treat one and see what's left over and then, address it? So again, with different people, we may approach that differently depending on the extent of symptoms, what other medical conditions there are, what other medications they are on, what their context is, what their occupation and the work shift and all those sorts of things are factors that we consider, but absolutely the two can coexist. And oftentimes the two need their own dedicated treatment for someone to have an improvement in their overall quality of sleep and the way they feel during the day.
Mhm. Thank you for that, Dr. Osama. Do you want to add anything there?
Yeah, I would say that, again, carrying on what Dr. Shelgikar said, that, there might be a two-pronged approach based on, like, their symptoms, or, we can go stepwise. But, if you have obstructive sleep apnea and, we started treatment and you're still having, like, insomnia, or if you're still having, like, daytime sleepiness, then please reach out, talk to your treatment team, because if you're still feeling sleepy after, like, using adequate amount of CPAP, and, like, your residual AHI, or, like, is low, or your therapy is very effective based on your device download and all of that. Still, if you're feeling like, daytime tiredness, fatigue, or sleepy, there might be other conditions that we might need to look at, because you know, essentially sleep is not fulfilling its function. It's just akin to me saying, if someone has kidneys and for them not to produce urine is okay, which is not okay. So if despite starting treatment, they're not noticing improvement in, like, their daytime symptoms or their nighttime sleep, if it's still, like, disrupted and they don't feel fresh, then they should talk to their team, because then we can look at other things which might be causing those symptoms.
All right. I do have a question here. Actually, let me just say, a lot of patients, are debate about using a nasal mask versus nasal pillows. And I think, is there a difference? And what type of patient should be opting for a nasal mask versus a nasal pillow for CPAP usage?
I think it all depends on, like, their preference, or if like, a lot of time choosing the mask is kind of like trial and error.
Okay.
So they have to try different things, but like, I mean, efficacy wise, they're both efficacious. Like, there is no one superior to another.
Okay.
Yeah.
Okay.
Yeah, I think also things related to anatomy and how open is the airway. There was a prior question about nasal congestion, right? That may influence the comfort of one type compared to the other. Also, the pressure setting. Sometimes having higher pressures delivered through the pillows can be uncomfortable. Sometimes it's a non-issue, but those are some of the things. So the best mask is a comfortable mask that you can use throughout the night, right? But those are some of the factors that may influence what somebody finds comfortable.
Okay. There was a question on that. And then last question, I think we're almost running out of time. What do you see as the most innovative development that is on the future horizon? I believe we addressed that earlier, but is there anything else you want to add?
I would just say
I think that
We're all excited.
we're all excited about this. This is what this is all about, right? I have a lot of, I'm talking to several companies right now that are innovating in several ways. And, I think that, if you're a patient, knowing that there are new treatments that are coming out, besides the medications will be very, interesting to a lot of people, no matter how severe the sleep disorder breathing is. So, I see some that are working on the airway. I see some that are working on using a medication for women specifically, and I'm very excited about that. I'm under NDAs with several companies, so I really can't talk a lot about it. But I do find that there's a lot of new things that are coming, and I think that the community is looking for new options to bring to patients. Not one thing. It's not a one size fits all solution. And when you look at sleep apnea, and I'm really excited about what's coming in the future. So go ahead, Usama, you're next.
Yeah, so I mean, I'm excited about everything. I think it's a very excited time to be in sleep medicine as a physician, but also it's a very exciting time for patients, because there are so many new options coming. And I think more options are always better because, then patient, if they don't tolerate or don't choose one option, they can, try another option. And, for a long time, we've been telling patients that, CPAP therapy is the only option. I've been telling my patients that there's no medication, but now there is a medication. And actually, there are so many medications in trial right now. Um, in the right patient, the key is that, based on your phenotype and endotype, there are so many options coming up. And so it will lead to more individualized care and precision medicine. So that is what I'm really excited about. I'm excited about everything happening. I don't have any favorites right now.
Dr. Shegikar.
I agree. I mean, even things like this, right? The webinar talking about obstructive sleep apnea. I mean, the recognition and the interest in obstructive sleep apnea and in sleep disorders as a whole, and in improving sleep health to improve quality of life and overall health and well-being. I mean, this is really what's driving innovation because it's important to people, it's important to patients, it's important to clinicians, it's important to researchers that we try to understand all of this better and try to have more personalized diagnostics, better therapeutics, better combinations of treatments for people. So all of this is really driving the field forward, and I'm really excited for what we're going to be able to offer our patients, not only in the short term, but in the years to come.
And what Dr. Usama was saying at ASAP, we've been saying right treatment for the right patient, and that's something we're advocating for. So I think we want to be in a place where every person is treated and they get the right treatment that suits them, right? For better quality of life and better sleep, better health. All right, well, thank you all today for this conversation. And I just want to let our viewers know if you have any questions for us or the panelists, please reach out to us. You can write to us at info@apneapartners.org. You can also visit AASM website, even ASAP website for information and resources. And then again, want to remind everyone about the webinar that I did with Dr. Audrey Wells, and that is available on our YouTube channel. So again, thank you all for the great conversation today and the insights. And I also want to thank all the viewers who joined us today. So thank you.
Thank you.
Thank you for having us.
Thank you for having me.
Thank everybody.